Hello, I'm Michael Trower, an emergency medicine consultant, and welcome to this video on point-of-care ultrasound and cardiac arrest. Let's start with a case. A 73-year-old female with an out-of-hospital cardiac arrest. She was found unresponsive, has bystander CPR for 5 minutes, then paramedic delivered ALS for a further 15 minutes. Her initial rhythm was PEA, but it degenerates into asystole, and her end-tidal CO2 is very low, only 0.7 kilopascals. This is the subcostal view of her heart that's obtained during the arrest. And I'll just give you a few seconds to put all this information together and consider, if you were the team leader, would you be more likely to continue the resuscitation or to stop the resuscitation? There's no right or wrong answer, and I've only given you very limited information. But the point I'm trying to make with this case is, even though there is some cardiac activity on that echo, so you can see a little bit of movement of the myocardium, the overall prognosis for this lady is unfortunately very bleak. So she was found unresponsive. There's an unknown downtime. She's had 20 minutes of chest compressions without ROSC. She's now in asystole with a very low end tidal. There's a few other factors that if you included, you could calculate a miracle 2 score that's likely to show that she's at a very high risk of poor neurological outcome at 6 months. So even though there is some cardiac activity on echo, unfortunately her prognosis is very bleak. And one more case, this time a 39-year-old female with an out-of-hospital cardiac arrest. This time it's a witnessed collapse. There's bystander CPR for 5 minutes, ALS for a further 10 minutes. Her rhythm remains PEA throughout, and her end tidal is 2.5. This is a parasternal long axis view of her heart. So we have the right ventricle in the near field, the left ventricle in the far field. And again, I'll just give you a few moments to put all this information together and just consider, if you were the team leader, would you be more likely to continue or to stop the resuscitation? So in this echo image, there's no movement at all of the cardiac muscle, the myocardium. There's a slight flickering of the mitral valve, but the muscle, the interventricular septum, you can see in the middle of the screen, and also the LV free wall in the far field, there's no movement there at all. There's no contraction of the muscle. And we know this is a poor prognostic sign, cardiac standstill. However, when you factor it in with all the other information, actually this patient's prognosis is relatively good. She had a witnessed collapse, so there was no downtime. She's only had 15 minutes of chest compressions. Her rhythm is PEA, which has a better prognosis than asystole. Her end tidal is good. And if we calculated her chance of good neurological recovery at 6 months using the miracle 2 score, actually she may have a pretty good chance of a meaningful survival despite the ultrasound findings. So these first 2 cases were supposed to demonstrate that the presence or absence of cardiac activity on ultrasound is just one factor that we should factor in with everything else when we're deciding when to stop or to continue resuscitation. I'm not going to talk about traumatic cardiac arrest today because that's really a different kettle of fish. There are well-established guidelines and protocols for this situation, which involve quickly decompressing traumatic pneumothorax, moving on to a thoracotomy if necessary, giving blood products as quickly as possible. So ultrasound may have a role here, but it's really a different scenario, so I'm not going to focus on that today. Similarly, ultrasound has less of a role in patients with shockable rhythms, VF and VT, since here the focus and the priority is early defibrillation. The only potential role ultrasound has in this group is differentiating fine VF from asystole, which is not always obvious from the ECG. So in the clip on the left, this is a parasternal long view, and if you look carefully, there is a quivering movement of the myocardial fibers. And in the clip on the right, this is a parasternal short axis, and again, if you look carefully, there's a sort of quivering, shaking movement of the muscle. So if you see this on ultrasound, you may be able to rule in VF and defibrillate. In terms of the potential harms of ultrasound in cardiac arrest, there's really just one main harm that we need to discuss, and that is delaying chest compressions. There have been some studies that have shown ultrasound can delay chest compressions, and so if you are going to use ultrasound in your cardiac arrest management, you need to make sure you avoid this, and the responsibility for this should be both on the person performing the ultrasound and on the team leader. Some centers even use a technique where they count down from 10, and as soon as you get down to 0, the person doing the ultrasound is told, step away, resume chest compressions, and this minimizes any risk of delaying chest compressions, which we know we must not do. However, there are various potential benefits for using ultrasound in cardiac arrest. Number 1, as we've touched on, predicting outcome. Number 2, identifying reversible causes. 3, identifying ELCOS, or extreme low cardiac output state, which we'll come to. 4, ensuring effective chest compressions. 5, identifying ROSC. And 6, ultrasound guided procedures. And the rest of this talk will go through each of these 6 potential benefits in turn. One of the seminal papers on this topic was from 10 years ago from North America, Gaspari et al. It was a prospective multi-center study looking at nearly 800 patients. They included patients with non-shockable rhythms, PEA or asystole, also non-traumatic, and survival to admission was increased with an odds ratio of 3.6 if there was cardiac activity on ultrasound. If there was no cardiac activity on ultrasound, cardiac standstill, then the chance of ROSC was only 14% compared to 51% if there was activity. Admission to ICU was 7% as opposed to 29%, and survival to hospital discharge was only 0.6% compared to 3.8%. So this represented 3 individual patients. So it's a strong predictor. However, there were still some patients who survived to hospital discharge despite having no cardiac activity on ultrasound. Next, reversible causes. So I'm sure you all remember your 4 H's and 4 T's, and actually half of these can be identified with ultrasound. So just to remind you, the 4 H's and 4 T's are tamponade, thrombus, tension pneumothorax, toxins, hypovolemia, hypoxia, hyperkalemia, and hypothermia. And which of these can be identified with ultrasound? Tamponade, thrombus, particularly a PE, tension pneumothorax, hypovolemia. So we can get a lot of information on these reversible causes from ultrasound if it's used wisely. In the Gaspari paper, they found 34 patients with pericardial effusion. 13 of these had it drained, and 2 of these survived. So it's worth looking for, because if you do identify it and you can drain it, then you have improved survival. Pulmonary embolism is another reversible cause that we should try and identify. However, right ventricular dilation is actually not very specific for this. There was a study by Argard where they took a load of pigs and put them all into cardiac arrest through different mechanisms, and they found that in all the pigs the right ventricle dilated. So it seems to be within about 30-60 seconds of arrest, the RV just blows out because it's a thin-walled chamber. So if you see RV dilation in the context of a cardiac arrest, this is actually not very specific to a PE. However, if you can find a DVT, this is highly specific for PE. And actually it's quite easy to do a 2-point compression scan for DVT, even during chest compressions. Just compress at the common femoral vein and popliteal fossa. You can do this in a few seconds once you've practiced and you're slick at it. And if you see a DVT there, then you can thrombolize, because we know this is very specific for PE. In the Gaspari paper, 15 patients received thrombolytics, and one of these did survive to hospital discharge. So again, if you identify PE, then we should be ready to treat. Tension pneumothorax. This is what normal lung sliding looks like. So there are ribs on the sides of the image. The bright white line is the pleural line, and you can see a sort of shimmering movement along that line. So you know there's no pneumothorax at that point. In this second image, we can see that bright pleural line, but this time there's no shimmering along that line. It's just static. That doesn't mean it necessarily is a pneumothorax, but that's what you will see if it is a pneumothorax. If it's only a relatively small or medium-sized pneumothorax, sometimes you can see the transition point from sliding to no sliding, as you see in this third image. However, if the pneumothorax has caused a cardiac arrest, it's likely a tension pneumothorax, likely the whole lung is collapsed, so you won't see this lung point, you'll just see no sliding on that whole side of the chest. Hypovolemia. We can assess for signs of hypovolemia by looking at the inferior vena cava and the LV size. Here's an empty collapsible IVC, but we can also look for causes of hypovolemia, so a big AAA, for example, or free fluid. Here we can see free fluid in Morrison's pouch between the liver and the right kidney. Terminology is important, so we're all on the same page, and we're moving away from pseudo-PEA as a term. Instead, we're using other terms, including ELCOS, which stands for Extreme Low Cardiac Output State. This slide is taken from one of my intensivist and pre-hospital colleagues, and from left to right, the first group is potential ROSC. This is when there's high velocity flow. The second is ELCOS, Extreme Low Cardiac Output State. This is when there's low velocity flow. The third is no cardiac output state. So this is when there's no flow, but there is some cardiac activity, movement of the myocardium. And then the fourth group is electromechanical dissociation. This is when there's no flow and there's no cardiac movement at all, so cardiac standstill. And here are some examples. This is ELCOS, this is parasternal long axis. The heart looks kind of normal, the valves are opening and closing, the muscle's moving. However, if you measured velocity, it would be low, and this would relate to an insufficient blood pressure for perfusing tissue. Secondly, we have NCOS, no cardiac output state. So here there's no flow into the femoral artery, but when you look at the heart, there is some cardiac activity, so the muscle is moving. And finally, we have EMD, electromechanical dissociation. So here, when you look at the heart muscle, there's no movement of the myocardium at all, just a tiny flickering of the valve there. And it is important to identify these different subphenotypes because the management can change. With ELCOS, we know that in this group, if you give a continuous adrenergic, such as a noradrenaline infusion, survival to hospital admission increases. And also another smaller study showed that meaningful survival improves in this group of ELCOS when you add in additional vasopressors. The fourth potential use of ultrasound in arrest is ensuring efficacy of chest compressions. We know from radiology studies, such as this MRI and CT slice, that if you just deliver your compressions over the lower half of the sternum, as is taught, then you'll actually often be compressing over the LV outflow tract or even the aortic root rather than the LV muscle itself. This has also been demonstrated with transesophageal echo studies where they found that the area of maximal compression of chest compressions is often over the aorta or the LVOT rather than over the LV muscle where it should be. This is a transesophageal echo clip. The clip slows down for a couple of beats, and you can see that the LV outflow tract, just to the left of the aortic valve in the middle of the clip, is being completely squished and obliterated by chest compressions. So there's no possibility that blood could come from the LV out into the aorta because that outflow tract is being completely obstructed by the chest compressions. This is what we would like to see. So here, just the left ventricle is being compressed, but the LV outflow tract to the right of the image, it remains open. So blood can be ejected from the LV into the aorta. And unsurprisingly, outcomes vary a lot depending on how effective your chest compressions are. In this study, if the LVOT was open, then 7 out of 8 patients achieved ROSC, whereas if it was closed, then 0 out of 11 achieved ROSC. There's a new chest compression device that's just coming into use across the UK called PoCUS, and as opposed to LUCAS, it has a movable arm. So you can actually position the location of chest compressions more easily. You can move the compressions down on the sternum, but also laterally. This gives the provider more control over exactly where chest compressions are being delivered. And if you feel like they're in the wrong place, they're over the LVOT or the aorta, you can move chest compressions down and you can reassess and see if that has now led to more effective chest compressions. The fifth potential role of ultrasound in cardiac arrest management is identifying return of spontaneous circulation. So there's various different ways we can do this. One is manually feeling a pulse. 2 is looking for a jump in end tidal CO2. 3 would be just looking at the heart on echo and just seeing if it's beating. 4 is using Doppler, and this is what we'll focus on today. 5, the gold standard, is an arterial line, but often if it's an out-of-hospital cardiac arrest, you may not have this available. We know that manual palpation of the pulse is unreliable. Some studies show the accuracy is only about 50%, and to do it quickly, the accuracy is even worse. And so the scientific community has been looking for other, more reliable ways to assess for ROSC, and one potential way is using Doppler. This study was published in 2023 and seems to be relatively simple. You just use your high-frequency probe to look for Doppler flow in the femoral artery, and it seems to be more reliable than manual palpation of the pulse or looking for a jump in end tidal CO2. Just to remind you about the Doppler effect, so Christian Doppler was a 19th century Austrian mathematician and physicist, and the easiest way to describe the Doppler effect is just to think about when an ambulance drives past you. When the ambulance is coming towards you, the sound wave gets bunched up and it becomes a higher frequency, and as it goes away from you, the sound wave gets stretched apart, and so it's a lower frequency. And all you're doing with Doppler is measuring this effect. So you're looking to see is the blood usually moving towards the probe or away from the probe. With color Doppler, there's a mnemonic called BART, B-A-R-T, blue away, red towards. In this image of the kidney, we can see there's arterial flow going towards the probe, that's red, and then there's venous flow going away from the probe, that's blue. The other type of Doppler is pulse wave Doppler, and here you have a little gate, and you put the gate in the middle of the flow on color Doppler, and when you activate it, you get a waveform, as shown here in the bottom of the screen. And if you measure the top of the peak of that graph on the waveform, this will tell you the peak velocity. So this first image, we're measuring peak velocity in the femoral artery, and the femoral artery is in long axis. However, in the study by Haddad from 2023, they actually put the pulse wave gate in the femoral artery in short axis, and you also get a similar looking waveform. It was quite a small study, 35 patients, and they found that if the peak velocity was more than 20 centimeters a second, then this predicts ROSC with a systolic blood pressure of more than 60 millimeters of mercury. They found the accuracy was about 90%, which is better than manual palpation of the pulse. Some practicalities about how to actually do this. If you are planning to do it, definitely practice beforehand. Don't just try and work it out when an actual cardiac arrest comes in. So practice on a healthy patient or a colleague beforehand. You want to use the linear or the high frequency probe. Choose a suitable preset or scale. So depending if you're on venous or arterial presets, this changes the Doppler scale. So you want to be on an arterial preset. If you're going to do it in transverse, I would usually slightly tilt the probe towards the head so you have a little bit more Doppler signal, and then put the pulse wave gate in the middle of the femoral artery. The sixth and final of the potential roles of ultrasound in cardiac arrest is ultrasound-guided procedures. So we'll touch on venous access, arterial line insertion, and pericardiocentesis. In terms of venous access, there's the ALS principle that if you can't get quick IV access, you should go for IO. However, with ultrasound, you often can get quick IV access. Where I work, we have 64 millimeter deep access cannulae, and these are great for preventing tissuing, but also they're often long enough to reach the femoral vein, which may still be open, as opposed to limb veins, which may be more collapsed. So often you can just put one of these long peripheral cannulas into the femoral vein and take blood and give medications through that. Arterial line insertion can actually be done during a cardiac arrest, during chest compressions, but this needs a fair amount of skill and practice. If you are going to attempt it, hover the introducer needle just over the top of the artery at the 12 o'clock position, and then during a brief pause in chest compressions, insert your introducer needle, thread your guide wire, and try and complete the procedure very quickly, just within a few seconds, so you're minimizing any disruptions to chest compressions. And we actually run, in our cardiac arrest study day, we run a simulation where you can practice doing this on a phantom with a ELCOS or a core pulse going at the same time to make it feel realistic. And you should really be able to do this in sort of 5 or 6 seconds. So it's not something we should be asking a junior member of the team to do. It should be the most experienced person, so you can really get that outline in very quickly. It does take a lot of skill and training to be able to do that, but it is a very useful thing because running a cardiac arrest is just so much easier when you have an arterial line in place. As we mentioned before, if you identify pericardial effusion and you think that's the cause of the arrest, you think tamponade is the cause of the arrest, then you should be prepared to treat it. So think about how you would actually do this in an arrest. Think about what kit you would use. Would you use a dedicated pericardiocentesis kit, or would you use something that you're more familiar with, like a central line kit? Where would you place the ultrasound machine? Where would you have your procedure trolley? Where would you stand? And there are various different approaches, but ideally you do it with in-plane ultrasound guidance. It can also be done subcostal without guidance, but if you can get a view parasternally where you can see the effusion, then you know there's no lung in the way. And if you use the high-frequency linear probe, you can follow the needle into the effusion just like you're doing any other procedure like a central line or a nerve block. So just think about it beforehand. Ideally run a simulation with a phantom, so if you do have to do it in the heat of the moment in arrest, you know exactly what to do. There are various protocols that can be used for ultrasound in cardiac arrest. Some just look at the heart, some also look at the lung, and then some of the more recent ones also look for DVT and for sources of hypovolemia, so AAA or free fluid, sometimes in different orders. This is the SHOC, SHOC protocol. There are protocols both for cardiac arrest and for hypotension. The principle here is that you start with the core views, so looking at the heart from a couple of angles, subxiphoid and parasternal. Then you look at supplementary views of the lung and the IVC, and then if necessary you look for additional views, for example endotracheal tube conformation, DVT, sources of blood loss, AAA and free fluid. And this is a flow chart for the SHOC protocol. So first you get your echo views. If this gives you all the information you need, for example, there's a big effusion and you want to just move straight onto pericardiocentesis, then you can stop there. You don't have to look at the additional views. However, if there's time and you think you need more information, then you move on to the supplementary views, the lung and the IVC. Again, if you see no sliding on one side and you think it's a tension pneumothorax, then stop there and treat. However, if you need more information and you have time, go on to the additional views, so abdominal, pelvic, aorta, DVT, and ETT tube placement. This is the Sesame protocol, which was created by Daniel Lichtenstein, an intensivist from Paris. And I'll just put this one up so you can see the timing column. So these are actually seconds going from top to bottom. So as you can see, you really need to get these views very quickly. So the lung scan, he gives you about 10 seconds. The DVT scan, another 10 seconds to do both sides. Then free fluid, you get like 7 seconds. Pericardial effusion, you get a few more seconds. So it's very quick. And I think this is right. Like it really should be a very experienced operator doing these scans who can get these views that quickly. It should be someone who's very slick and has done this lots of times before on patients who are not in cardiac arrest. It shouldn't be someone very junior who hasn't done it very much and is taking a long time to get each view. So if you're happy with the SHOC protocol or the Sesame protocol, that's absolutely fine to keep using those. I like to be a little bit more flexible in my approach. For example, if it's an out-of-hospital arrest and the paramedics have just moved the patient across into the A&E resus trolley and we're starting with a pulse check, then I'll quickly do an echo with that initial rhythm pulse check. and I'll be looking for tamponade, RV dilation, and ELCOS or NCOS. Then during the next 2 minutes of chest compressions, I'll look for lung sliding, look for signs or causes of hypovolemia, and look for DVT, and potentially also using femoral artery Doppler to check for the efficacy of chest compressions. On the other hand, if there's a delay, perhaps the team leader is not quite ready for the initial pulse rhythm check yet, but I'm ready with my ultrasound probe, I might start with lung sliding. So while we're waiting for the echo view, I'll just quickly check the lungs. Then, when we're ready to do the pulse rhythm check, then I'll move on to the heart and go through the rest of the protocol. So look at the abdomen and the leg veins. So I think you can be somewhat flexible so that you can get all of this information as quickly as possible, minimizing any delays to chest compressions and working with your team so that you're not getting in the way of other important interventions. Finally, just touch on confirming endotracheal tube placement. So here's what the airway looks like on ultrasound. So you have the thyroid gland sort of to the sides of the trachea, and then if the trachea is air-filled, then you just get this kind of, looks a bit like lung. You get these horizontal lines, a bit like A lines in the lung. And then you can see the esophagus to the right of screen, just next to the trachea. If you put an endotracheal tube into the esophagus, then it looks like a little mini trachea, baby trachea. It's now air-filled, and so it has that same kind of appearance as the trachea, with a convex, bright surface in the near field and then shadow behind it. If you hold the probe on the patient's neck as you're intubating the trachea, then you just see a sort of slight change in the trachea itself. You see sort of movement within it, but you don't see anything popping up adjacent to the trachea. So as the tube's going in, you'll see something moving where the trachea is in that same region, but you won't see anything else appearing on either side. This is what it looks like if you intubate the esophagus. So if you hold the probe on the patient's neck as the person managing the airway is intubating, and you see this, then you can tell that person, I think you may be in the esophagus, consider pulling back and reinserting. So here, the esophagus to the right of screen, which was empty, suddenly becomes air-filled, and so it takes on the appearance of the trachea, like an air-filled structure. So you get that convex, bright line at the front and then a shadow behind. Okay, some take-home points from today. PoCUS can identify several of the 4 H's and 4 T's, and I actually think this is the most important role of ultrasound in cardiac arrest. DVT is highly specific for PE, much more specific than RV dilation. So if you can identify a DVT during an arrest, then have the confidence to thrombolyze based on that. We talked a little about terminology, ELCOS, NCOS. If you do identify a patient with ELCOS, so there is synchronized cardiac activity, but it's just not sufficient to create a blood pressure, think about starting this patient on a continuous infusion rather than just 4-minute bolus adrenaline. We also know that if you just deliver your chest compressions based on anatomical landmarks, the lower half of the sternum, then you're actually often over the LVOT or aorta. So consider using ultrasound to identify this and move your chest compression position down towards the feet and to the patient's left. And finally, some new evidence about using pulse wave Doppler over the femoral artery to identify ROSC. If you have any questions or comments on anything we've covered today, I would love to hear from you. Please send me an email at michael.trower@nhs.net. Thank you.